a patient, female of 68 years old, who medical history starts at August 2010 with occlusive syndrome. And the surgery found a small bowel neuroendocrine tumor, the T3N1M1 with liver metastases. Her disease was stabilized with lanreotide therapy, but at January of this year, she had a CT scan of follow-up who showed a stable liver metastasis, but progression in size of a celiac node. She performed a US FNA of the lymph node, who showed a grade 2 neuroendocrine tumor with a Ki-67 of 5%. Those are the images of this examination, this exam, and this case is proposed to be performed by Dr. Giovannini and Dr. Archidiacono with a US guided with radio frequency ablation. Room 2.
Hello again. It's quite the same story that the case you perform. It's a patient with neuroendocrine tumor, and she has an evolution, clinical, and also on the imagery of this one big node that you have on your screen. And I will perform first the sonoview, the radiofrequency ablation, and again the sonoview after to see if the treatment will be good. Okay, we will start the first sonoview. Okay, you can inject, please, to see the image here. We will see if we have an enhancement.
It seems to be a very well demarcated lesion, and
you see you have a nice
enhancement with big vessels inside. So this means a malignant lesion usually.
Yes. This is malignant, and we have the confirmation by the sonoview and the first biopsy that I performed. And this is interesting because this the primary lesion has a Ki-67 or less than 2%. Now it's 5% on this node. Huh?
So
okay, and here you have the second sign is the quick washout of the lesion after the sonoview injection. Huh?
Yeah.
Okay, now we
nicely see. Okay, you can nicely see that there is only during the systolic part the contrast enhancement. That means you have a high resistive index, and it's a high indication for malignancy.
Okay, this is the image that you like, Christophe, with the small vessel, with the fusion. Okay.
Oh, nice.
This is very nice, really.
This is because the patient is very well sedated by Vincent, which is an expert in anesthesiology. Okay, now we move for the
less until here.
Okay,
that's okay.
Okay, for the radiofrequency ablation, I will come back to the standard image.
So we
Mark,
have already measured the lesion is more than 3 centimeters.
3 centimeters. Yeah. Okay, it's the same. Needle that Paolo used this morning. You just put a little bit at the level
Closer.
of the.
Yes.
Wait. Yes. You can ask the question. Yes. Okay.
What is the concept behind? We have liver metastasis, and we have
but
that
this patient,
lymph node.
this patient has only one node which increase in size with the endocrine syndrome appear again. And the goal is to do
mass reduction concept.
Yes, reduction. Yeah, I have. You see, this is the. We have a small problem with the.
No, it's okay.
It's okay.
Yeah.
No.
You are in a. Maybe you are in a.
Should change my position. Yeah. But I'm not sure to find. Oh, okay. Now it's okay. And I hope to find again the lesion. Okay.
Yeah,
yes, the lesion is still here.
Okay.
It's a very kind lesion.
doesn't
Okay,
disappear.
I block my I block the wheel of my scope, and I will
It's very important with this
Yeah,
device
to
to
check.
adjust first
Yes.
the.
I think
the-
this is okay.
okay.
This is enough. Now I
Did
will.
the patient get antibiotic
Yes.
prophylactic treatment
yes.
in that
yes.
case?
Yes. Yes. Yes.
What
What
antibiotic?
antibiotic do you
And-
do for this case? It's cefazolin. Okay. Now we are in place with the needle, and okay, I will try to find the long axis of
Yes.
the lesion. It's not easy to.
The position
Okay.
right away is not that easy.
I will try to find the needle, but no,
No,
I'm not
it goes-
inside. Yes,
Yeah.
no, yes,
it
yes,
was,
yes,
It was.
yes.
It was.
I think yes.
So you aim for the center of the lesion,
I
or
will
what is
try.
your aim to
It's
position
right
No.
the
in
needle?
No, it's not good. This is, I'm inside, but not.
But not right in the center.
Yes.
So it's better to try to
because
change
it's
the
a
position.
14 gauge needle. It's not.
It's not so easy because it's 1.8 millimeters wide, so it's sometimes can be difficult to.
Okay, now this is much better.
Now you are.
Okay, we are.
Okay.
And what is the marker? And the marker is that this is the tip of the lesion.
You can go in. Okay.
Yes, a little
It's
bit
better.
more.
Try to reach the edge, the distal
Yes.
edge. Okay.
I
Okay,
think it's
now
not so
it's
bad. Huh?
not
We
so
have the
bad
free
because-
marker in the
Yeah.
middle of the lesion,
Because this is the last one.
Yes.
Is right.
and we
Okay.
are far away of the gastric
Yeah,
wall.
yeah,
Huh?
yeah,
Okay.
yeah. And this last one is only not an active
Yes.
electrode. It's just
Okay, if you have the endoscopy image, you see the needle, and we will start the.
We are ready. We have fixed 3 minutes because it's 3 centimeters.
Okay, we
so
start.
You can start.
No,
It's not working.
something wrong.
Activate again. Try again. Okay.
Now it's okay.
Now it's okay.
And
Now it starts working. So you see
Yes.
here that there is some hyperechoic surrounding to the needle. This is the cryo that is working because the cryo tends to create hyperechoic area surrounding the needle. Sometimes it's very easy to see quite a nice ball surrounding
okay.
the needle.
but
so-
the cryo is just to cool the
the mic.
needle to prevent the carbonization around the needle.
The cryo, the meaning of the cryo is to increase the capability of the bipolar
Oh,
radio
yes.
frequency to destroy the tissue.
You see
And you
the.
see some bubbles coming, but still the
The
our
question is this RFA or
Yeah.
this is cryotherapy? You said
No, is a RFA.
RFA,
RFA.
bipolar RFA and cryo technology. And it's-
Could you explain a little bit of the machine? What kind of numbers do you see
Yeah.
and put in, and what is the size of necrosis you expect by doing this? 2 centimeters or 3, or
actually
is it time dependent which size of necrosis you will get?
Yeah. What we expect is that the longitudinal axis of the necrosis will be the longitudinal axis of the electrodes, so nearly from 2.5 to 3 centimeters long, and this cross-sectional, so the transverse area of the necrosis that we expect usually in pancreatic cancer, because these are the first 2 trials that we do on lymph nodes. The size depends on the time that we apply the probe. So in this case, we have fixed 3 centimeters, so 3 minutes.
3
So we
minutes.
expect to have at least from 2.5 to 3 centimeter necrosis on transverse size.
But
in
we,
this-
we
in
can
this.
we can apply 2 times. If I remove a
Yeah.
little bit the needle, I will treat maybe the area not treated.
Yeah, usually we prefer, in our experience in the pancreas, we
Yeah.
prefer to do 1 procedures 1 time. So we do the first procedure, then we go back after 1 month, and then we can do a second
Yes.
treatment.
I think this is the
because
good option. But here
because-
you see that
yeah,
the
it's going-
necrosis
it's
is
going very well, and
yeah.
also as you can see the figures that
Yeah.
that show the impedance of the tissue that are going completely parallel. So this means that the instrument is working good. It's finished because we have fixed the 3 minutes.
Yes.
So
But
it's finished
if
by
I
itself.
remove a little bit
Wait.
the needle like this, I can do a little bit more.
The most important thing is that you have to keep the probes inside the
Yeah,
lesion.
yes, I
Okay.
mean,
Yeah.
maybe I will start not for 3
So there's
minutes.
a question
You
from
can,
the
you can
audience,
start
Ryan.
and you can
Yes, just to treat this area.
You can stop
Yes.
the procedure whenever you want.
Yes.
Paulo,
Yes.
Paulo, there's been some new probes from Korea,
Some-
new RFA probe from Korea.
Yeah.
I can.
There's been a new RFA probe from Korea. How does that compare to the ERBI probe?
Oh, the RFA
in
probe
the
from
amount
Korea
of-
is a monopolar. It's monopolar probe and has no cryotechnology inside.
But
So
yes.
it's completely monopolar. And the problem of the monopolar radio frequency is that you cannot really well control the flow of the flow of the radio frequency, because in bipolar probes you can control the flow of the radio frequency because you know that the flow is surrounding the two electrodes. In the
Okay, I
the
think
monopolar
I
you
will-
can
I
stop.
will
if you-
stop. Yes.
Yeah.
1 minute more.
Yeah.
Okay.
Okay.
Now I think it's enough.
So you can clearly determine with the bipolar which size and that you can ablate. With the monopolar, you cannot decide, and so the flow of the radio frequency is not going only in one direction, in one circular direction, but can flow also in front of your needle. So it's the problem of the radio frequency, monopolar radio frequency needle that has
Preparez
been
le
shown
sonoview.
also in the
Yes,
in the
I
laparoscopic
wa-
and laparotomy papers is that you can burn the big vessels wall.
I wanted to show also this probe during this meeting, but the probe is not available today.
up
We
today,
don't have
yeah.
the
But it's
Yes.
clearly you can
Yes.
see here if you
Yes.
focus on that.
Yes,
Okay,
yes.
this is the track of the needle, and
yeah.
you see clearly that since the first time you see here that there is a changing of
Yeah,
the
yeah.
pattern, the echographic pattern of the tissue. This is very important.
we will see with
because
yeah.
it gives you an idea of the first
we will
necrosis that you
see
have
with
obtained.
the sonoview, huh?
Yeah. Now with the
We're
sonoview.
very much excited to see the site
Pardon?
of the necrosis.
We have
And
done.
this is
we
the
have done.
advantage of contrast
done,
ultrasound.
Yes,
yeah.
we do the contrast
We
now.
will do the
Okay.
contrast. And,
Okay, go.
We have done an ex vivo study to detect the necrosis in the adenocarcinoma, and it's very important to notice that the necrosis
You flash?
is
Okay.
very related
You
with
see?
the. Okay.
The center
You
now
see,
is
you see that the center is not enhancing anymore. Can you see? There is no enhancement
Yeah,
now.
make a freeze and measure.
Yeah.
Perhaps micro bubble tracing imaging, you get it.
It's
from
2
here, it's
centimeter.
difficult to
2
delineate.
centimeter and
by
that.
by 2.
2 by 2.
2 by
But
2.
this is the first step, because we know that from our first study that
But you see this area here, there is no enhancement. Huh?
absolutely no answer.
Here, if
Can-
you
you
put
can-
Could you
you
do micro
can-
bubble
okay,
tracing
perfect.
imaging?
yes, here you see.
Yeah.
This is
Ye-
the ablated area. Yes, if you.
You can see this is the ablated area now.
Very nice job.
Huh?
And what we can say is that in our previous study we have shown that there is since the beginning a very well demarcated necrotic tissue surrounded by another part of tissue that is not already dead, but for our pathologist is a tissue that has some changes that are compatible with a tissue that is going to die in the next few hours. So to be sure about the volume of the necrosis that you caused in the lesion, you should wait for
Yes.
some
Yes.
hours. Usually we perform after 2 days a CT scan in our randomized control protocol on pancreatic cancer to show the effect of the necrosis of the treatment in the volume of the necrosis.
But here you see also with the standard
Yeah.
Doppler that this area is
completely
Hello?
necrotic.
Hello?
Yes, Nick.
Paolo, we have a question from Ron. The Chinese have come up with data on iridium implants causing some form of ablation. Has there been any data comparing
I'm
these
sorry, I
two
can't-
modalities? Iridium implant.
Iridium implant. We don't. Unfortunately, we don't perform this.
The problem of the implantation of seed seeds is we should have a three-dimensional a three-dimensional aspect of the lesion, because if you do the insertion of seeds, it's easy to it's like the fiducial, but you put only in one same plane. And you cannot treat the volume. This is the difference with the radiofrequency ablation, that we can have a volume ablation and not a flat treatment.
Yeah, and particularly with the bipolar probe, because the effect of the current is flowing around the two probes, so you have a very nice elongated but quite circular lesion. So it's very safe, and the volume is very specific.
Okay, I don't know if
last question.
new room.
One more question
Yeah,
from
of course,
the
of course.
audience.
Just quick question. In this patient, you inject the whole ampulla of Sonoview, a half the first time and another half the second time, or two ampulla?
No, it was we are rich today. It's two ampulla. Yes, but you can do half and half. It's for neuroendocrine. The enhancement is very quick, and you can inject the 4 milliliters and 4 milliliters. It's not there's no big difference.
So no more complication with two ampulla by patient.
You know the
So,
complication.
what is the size?
The complication is a
The
patient
size of the
with. Okay. The complication is a patient with heart disease. Of course, this patient was a check by the anesthesiologist,
Absolutely.
and of course, there is probably it's more risky to do a Sonoview in a patient
in a young patient.
with no anesthesiology
Yes.
checking
Ambulatory.
before
Yes,
ambulatory for liver disease than
Yes.
for this patient, because these patients are checked by the
Always checked.
anesthesiologist. It was under complete control during the procedure. I think no,
Yeah.
but the main contraindication is the
the
coronaropathy
Yeah.
with unstable disease.
Yeah.
There's one more question
Yes.
from the audience.
Question I had initially, and he did not answer. Is this RFA or this is cryotherapy?
It's RFA.
RFA. He keeps saying cryotherapy as the initial modality he applied initially. I mean, in the same case. So this is RFA, not cryotherapy.
No, this is RFA.
So there was a question.
So this one is an RFA. I mean, when do we use this local modality? Is it like an adjunct with the definitive therapy, or this is as a palliative
This is
patient in particular?
this is two select case. We have had a long discussion with the oncologist who treat this patient. It's a very special case with a very long history of neuroendocrine tumor with a stable disease, and the patient recure the endocrine syndrome in a very focused area in the lymph node for the two patients, and the goal is to do just a tumoral reduction. But this year there will be two studies. We start in France, one in France and one it was an international study on and Paolo is the main investigator. One is for the pancreatic tumor, and this study is a randomized study. This study which compare chemotherapy for the locally advanced tumor, non-resectable. They compare the chemotherapy versus radiofrequency ablation with the hybrid term plus the same chemotherapy. And there is a French study which the goal is completely different. It's for the IPMN with mural nodule and the small pancreatic neuroendocrine tumor, which the promoter is the French Society of Endoscopy with the Taiwan company with this monopolar probe. And this is a phase 2 study on this special patient who refused the surgery or patient in which surgery is contraindicated for general disease. But this is the 2 study that we will start very soon this year. And the first study of Paolo is just start.
It's already started. Yes.
Has already started.
Yeah, yeah.
Okay, but now we should change
Could you give us the
yes.
room? Thanks.
We should change the room.
Could
huh?
you give us information about
Yes.
liver mass volume? How large are the metastases of the liver in this patient? Is it a huge tumor
The
volume in
metastases on the
or
liver for
only-
this patient are stable. But you can assess the left lobe of the liver, and you can treat a small liver metastasis with the radiofrequency ablation, like you do the ablation in.
This system has been already tested on liver as well, so we know that the efficacy of the system in the liver as well. So in the future, probably we could treat the metastases, the liver metastases as well with the same device.
Okay, we should change the room now for a new case. Thank you very much.